This presentation focuses on theory approaches for smoking cessation to prevent strokes in men living in the Los Angeles area who are 55 and over and engage in smoking. We're group 5. My name is Jackie.
My name is Leslie.
Hello, everyone. My name is Christina.
Hello, everybody. My name is Evelyn.
Hello, guys. This is Fabiola.
Hello, everyone. My name is Yana.
In this presentation, there will be an overview of health issues, behaviors, population, and the theories that are going to be focused on is the self-esteem enhancement theory, protection motivation theory, social support theory, multiple streams theories, and there will be a theoretical framework as well. Again, these theories will be applied to men living in the Los Angeles area who are 55 and over and engage in smoking. Health issue is stroke. So what is a stroke? A stroke is something that occurs when blood flow to the brain is blocked or ruptures. This thing deprives the brain of oxygen, which can lead to cognitive defects and even death. There are two main types of strokes, one being the ischemic stroke, and that one is when blood flow to the brain is blocked or reduced. This type of stroke prevents brain tissue from getting oxygen and nutrients. Within minutes, brain cells begin to die, and it's actually one of the most common strokes to occur, with 85% of strokes being this stroke. Hemorrhagic stroke is when there is a blood vessel that is leaking and then bursts, causing bleeding in the brain. When there's bleeding in the brain, a lot of the times pressure will form, causing brain cells to become damaged and also die off. Some of the symptoms included when someone is having a stroke is they have trouble processing information cognitively, so they're not able to form words properly. They have trouble speaking. They have trouble forming sentences. So a lot of times they will start saying things that don't make sense in the situation, and use improper words and just not be able to think clearly. Another sign of a stroke is numbness and paralysis. A lot of the time, strokes focus on just one side of the body, whether it's the left or the right. And a lot of people can notice this because they'll start seeing drooping in the face. Also, one of the things that will occur is that they'll feel numbness or tingling in their arm. Again, also on just one side of their body. The outcomes of a stroke a lot of the times are brain damage, cognitive impairments, weakness and paralysis, and they have speech and language issues. Again, all of these are due to blood flow being blocked in the brain and the brain cells beginning to die. Many times they last up to a year or even for life with these damages and require a lot of physical and occupational therapy to regain either their hand movements or regain their ability to properly speak and think clearly. For many individuals, these things never go away. How does smoking play a factor into this? So smoking does a lot to a person's body, but the biggest things is that it increases the buildup of plaque in blood vessels. This is due to a lot of the times when people are smoking cigarettes. Cigarettes have tar, and when you're inhaling that plus 1,000 other chemicals, it causes plaque to build up in the blood vessels. Because of this plaque buildup, a lot of the cells are then damaged and they are narrowed because of the plaque. Even in blood flow, it becomes sticky and it's easier to cause blockages in someone's body, therefore increasing the chance of stroke. It's also it's easier for it to clot, again causing more blockages in the brain and in the heart. The epidemiology of smoking. So 1 out of 5 Los Angeles County residents participate in a form of smoking, whether that be tobacco use, marijuana use, vaping, or any other type of smoking. 22% of men in Los Angeles also smoke, which is a lot of a higher rate than women, which sit at a 14% rate. Population profile. So the prevalence of a stroke increases as someone's age increases. In Los Angeles County, people 50 to 65 had an increased prevalence of stroke by 7.1%. Yearly in the United States, there are 800,000 new stroke cases a year, with men's cases being a lot higher than women, therefore putting them at a higher risk of stroke. They are also one of the leading causes of death in Los Angeles County, primarily with men. I believe they're second along with heart disease. A lot of the times, individuals have difficulty quitting smoking because of how addictive the nicotine is. Nicotine triggers a particular part of the brain that releases happy hormones. So a lot of people feel the need to keep doing the nicotine to feel the happy hormone again. It triggers that specific part of the brain that it becomes a normal function for them that they feel like on the daily they need it to survive. Chronic disease in people aged or in men aged 50 and over is what triggers smoking cessation a lot of the times. These diagnoses of chronic diseases will cause them to make the change, but a lot of the times they've been doing it for many years. Some examples of the chronic diseases that they can be diagnosed with is stroke, coronary artery disorder, and hypertension, which goes hand in hand with strokes as well. Attitudes towards the behavior of smoking is also a major factor in wanting to quit. Many people do not believe that they can quit, and that is a big issue as to why they don't. A lot of them will try and do it just from one day to another when it is not an overnight solution. A lot of the times it takes up to 7 attempts for someone to fully quit doing a behavior. In a study that was done in 2020, they found that a group of stroke survivors of the group, they found that 20.4% of the stroke survivors continued to smoke post-stroke when they knew the dangers of it, therefore triggering a reoccurrence of a stroke in the future. In Los Angeles County, there have been smoking prevention programs that have been developed, such as tobacco use education programs that have been developed and given to individuals in schools or in rehabs. A lot of the times they're done at young ages to prevent them from in the future developing a smoking issue. There's also smoke-free tobacco cessation programs where they help individuals stop from smoking and often go through a rehab program. Now in Los Angeles County, there's also smoking regulations and ordinances. For example, a lot of the times in restaurants, they are not allowed to smoke in there for the safety of them and other people, as secondhand smoke can be just as dangerous as firsthand smoke. Another thing is many universities, such as Cal State Northridge, have a non-smoking policy on their campuses, as well as many of the other Cal States.
Okay, so for the first theory being covered under the intrapersonal level, is a self-esteem enhancement theory, SEAT for short. This offers an evidence-based interpersonal approach to promoting smoking cessation for stroke prevention among older men in the greater Los Angeles area. So this population faces disproportionately high rates of stroke, with smoking remaining one of the most significant contributors to that risk. Next slide. An overview of the theory is once again, it's a self-esteem enhancement theory, and it was developed by Howard Kaplan in the 1980s to explain how diminished Self-worth increases vulnerability to health risk behaviors, including smoking and substance use. Although originally applied to adolescent population, Kaplan's work evolved to include adult populations, particularly those experiencing social and emotional challenges. C hypothesizes that improving self-esteem provides individuals with a psychological resource that facilitates healthier decision-making, reduces reliance on harmful and coping mechanisms, and promotes long-term behavior changes. This framework is particularly relevant for older adults. Next slide. The self-esteem construct theory consists of 4 key constructs that explain how emotional and physiological factors influence health risk behaviors such as smoking. The first is global self-esteem, and this refers to an individual's overall evaluation of self-worth, encompassing feelings of competence, value, and personal acceptance. Low global self-esteem has been linked to greater vulnerability to health risk behaviors, including smoking, as individuals may lack the confidence in their ability to make positive health choices. The second is contingent self-esteem, and this is a form of self-worth that depends on external factors such as achievements, social approval, or validation from others. Individuals with contingent self-esteem may experience fluctuations in self-worth based on success or failure, making them more susceptible to behaviors like smoking, to coping with feelings of inadequacy or rejection. For the third construct is coping mechanisms. And so according to C, individuals with low self-esteem may adopt harmful behaviors such as smoking as a maladaptive coping strategy to manage stress, anxiety, or negative emotions. Smoking in this context provides temporary relief, but reinforces a cycle of dependence. And for the last construct, health behaviors as identity. Health behaviors, including smoking, can become intertwined with one's identity, particularly with behaviors that reflect perceived social roles or cultural values. For older men, smoking may be tied to traditional ideals of masculinity, independence, or control. C emphasizes the potential to reframe quitting smoking as a positive identity shift, representing strength, self-discipline, and autonomy. Together, these constructs provide a comprehensive framework for understanding how self-esteem influences smoking behaviors, especially among older adults coping with age-related stressors and identity challenges. Sorry. So why C applies to men 55 plus smoke is in the Los Angeles, over 600,000 aged 55 and older face increased smoke risk due to tobacco use and other modifiable health behaviors. Many individuals within this demographic experience social isolation, particularly after retirement, loss of social roles, or health decline. Historically, smoking has been marketed as a symbol of masculinity, control, and independence, contributing to sustained tobacco use in this group. C is well suited to address these emotional drivers by promoting quitting as a form of empowerment, reinforcement, self-worth and fostering improved health outcomes. As for the rationale for choosing for this stroke prevention, stroke remains one of the leading causes of death and disability in the United States, and smoking significantly increases stroke risk, particularly in older adults. For men age 55 and older, smoking cessation represents one of the most effective strategies for reducing smoke incidence. However, many cessation interventions fail to account for the emotional factors contributing to sustained tobacco use. C addresses these underlying self-esteem challenges, reframing quitting as a gain in self-control, personal strength, and overall well-being rather than a loss or a sacrifice. I think I'm okay. It offers several strengths for smoking cessation interventions targeting older men. The theory aligns with cultural values of independence, control, and personal achievement, making behavior change feel empowering rather than imposed. C is adaptable to the lived experience of older men as well, many of whom face declining health, isolation, and reduced social engagement. It promotes sustainable, internally driven behavior change by enhancing self-worth. And some of the limitations could possibly be improvements in self-esteem require time and sustain engagement. Facilitators must possess the skills necessary to address complex emotional dynamics. And C is most effective when used in combination with structured smoking cessation programs and broader support systems. This is some of the supporting evidence. Self-esteem predicts smoking behavior, especially in adults, boosting self-worth, reducing health risk behaviors, and self-esteem promotion improves mental and behavioral health outcomes. For the conclusion, self-esteem enhancement theory provides strength-based interpersonal approach to promoting smoking cessation and reducing stroke risk among older men in Los Angeles by addressing the emotional and physiological factors that contribute to tobacco use. The supports behavior change rooted in empowerment, self-identity, and resilience. Integrating seat within public health interventions enhances the likelihood of long-term sustainable reduction in smoking, ultimately improving health outcomes for this high-risk population.
So the next theory that's going to be covered in this intervention is the protection motivation theory, and this is at the interpersonal level, which is the individual level. So this theory was created by Ronald W. Rogers in 1975, but was later revised in 1983. And during this revision, he essentially just expanded on the cognitive and coping processes. This theory is used to predict health behaviors and intentions. So essentially, it examines why individuals choose to perform the health behaviors that are protective. It's essentially the motivation when we are faced with health risks. So it is divided by two cognitive processes. The first being the threat appraisal. This entails the seriousness and the likelihood of the threat impacting a person, while the coping appraisal is more concerned with an individual's ability to actually do the behavior. So the protection motivation theory has 7 constructs, the first being perceived severity. This is just the seriousness of the threat, and when it comes to older men, they may think about factors such as how stroke can lead to death, it can lead to brain damage, and long-term disability, and these are things that they're going to be considering. Then there's perceived vulnerability. This is the likelihood of them being exposed to the threat. Whenever men are older and they've been smoking for a long time, they're usually not going to be thinking about how, oh, I might have a stroke one day. But when they take into consideration factors such as how smoking is one of the biggest factors when it comes to stroke and also age, as you grow older, your risk for a stroke increases. Then comes intrinsic rewards. These are the benefits that are internal. When a person smokes, especially when it comes to men at an older age, they find comfort in it. It calms them down, in which they engage in this risky behavior. Then comes the extrinsic rewards. These are the social benefits and the negative outcomes. And in this case, it would be men smoke, usually in LA area, many people smoke, and it's due to socialization. People like to socialize as they're smoking. The next construct is response efficacy. So this is the effectiveness of the actual behavior. So whenever a person is going to think about how they should quit smoking, they're going to think how it will reduce their risk of stroke, which is very important, and it will better their health status. Self-efficacy is the next construct, and this is just one's ability and confidence to actually do the behavior. So men are going to question themselves and ask, can I actually do this? Can I actually quit smoking? Is this something I'm able to do? Lastly is response costs. These are the barriers and the costs of the behavior. And when it comes to older men that have been smoking for a very long time, they're just going to think about withdrawal symptoms. This includes weight gain and also just stress in general when it comes to trying to withdraw for something that has been a habit for a really long time. So the protection motivation theory tells us how intentions are come from a place of a thought process. And it really shapes how a person interprets a health risk and how capable they feel with dealing with it. When an individual starts to think about a threat, specifically stroke, they're going to think about how quitting smoking is one of the best solutions, essentially to reduce their risk, and they're going to believe it's necessary, and this is when the intention is going to be formed. Intention is a huge factor when it comes to actual behavior because without it, the actual behavior will not happen. For example, an older man who has been smoking for a long time is not going to plan to quit unless they have the motivation to do so. Fear is also a very powerful tool, specifically in this case of stroke. It's the motivator. This is going to motivate them to actually apply the change to happen. Fear is also helpful for people to realize their personal risks that they're facing. And also, fear just sparks the motivation that is necessary to make a positive change that will essentially better a person's health status. When it comes to previous use of the protection motivation theory, there have been many times when it's been used in previous studies. This specific study has shown that coping appraisal compared to threat appraisal alone worked better when it comes to quitting smoking. And it also demonstrated that perceived severity and vulnerability and a stronger coping appraisal together were linked to quitting. Along with response efficacy, one of the constructs was an important factor to actually drive the intention. And also, this study showed how the protection motivation theory can be measured quantitatively in an intervention, specifically through surveys. So we can essentially, during this intervention, use it to survey people based on each construct and see where their thought process is. When it comes to the strengths and the limitations of the protection motivation theory, the protection motivation theory has been applied to many different age groups, many different contexts, but it has been continuously used in the older population, specifically men, and especially when it comes to interventions of smoking cessation, in which it would make a great framework. And it also shows how fear and confidence are linked together and they're used to take action, especially when it comes to these protective health behaviors that will benefit a person. And when it comes to the limitations, there are a couple. First, being that most of the designs are cross-sectional. This means that it focuses on one point in time rather than looking at the long-term scale. So, this necessarily means that we can't see how the motivation or the behavior changes with time. Also, it doesn't fully consider the past behaviors of the person's habits, which can be an important predictor when it comes to determining what their intentions are. And also, it might miss a significant pattern that influences how a person responds to threats. Essentially, the protection motivation theory is a strong evidence-based foundation that can help with this intervention as it increases personal awareness and helps people go through this cognitive thinking process and helps them realize the threats that they have while also looking at how they can deal with it and make the positive protective behavior change that is needed, especially when it comes to this age group of men who have been smoking for a very long time and this is impacting their health in a negative way by increasing their risk for a stroke, in which quitting smoking is needed.
So now moving on to the interpersonal level. The theory chosen under this level is the social support theory, also known as SST. Social support theory explains how a person's social relationships influence their health behaviors and outcomes. It is actually rooted in the idea that people are more likely to make positive changes and keep them when they feel supported, valued, and connected to others. According to Lee Westmath et al. 2010, it also suggests that support from others can help people cope with stress. It helps them build confidence and successfully change behaviors. This theory has the constructs under this theory is emotional support, instrumental support, informational support, and appraisal support. Emotional support's definition is more on the empathy, the care, and the encouragement of that for the individual. Under instrumental support is more on the practical help and the services provided to the individual so they can be assisted in not smoking anymore. The third one is the informational support, which is advice, knowledge, and suggestions. And fourthly is the appraisal support, which is just feedback and affirmation. I'll touch base more on the next slide, please. So the application on the social support theory on men over 55 with the health behavior to quit smoking. One, emotional. So for emotional, it's like I mentioned earlier, it's expressions of empathy, caring, encouragement. In this case, what we can do for the family member is that they can regularly check in and say, "Oh, you've come so far, don't give up," reinforcing their confidence to quit. This also can help them reduce stress and emotional triggers that often lead to relapse. For the instrumental support, this is the tangible, as I mentioned, tangible aid or services provided by others that surround the individual to help them take action. This, for example, this is for like a friend or a neighbor that gives, a friend or a neighbor that can give them a ride to get free cessation support group advices at a local center, or can help them take them pick up nicotine patches, for example, from the pharmacy. This falls well under instrumental support. As for informational support, Again, this is providing advice to the individual, facts, resources, or guidance to help them to assist them make a better decision. In this example, it could be like a community health worker that explains how smoking increases stroke risk and offers tips on managing cravings or where to get free counseling. As for appraisal support, it's support groups or family members, again, that can provide positive feedback. So in this case, a support group can give the individual appraisal for staying smoke-free for 1 week, helping him recognize his progress and stay motivated. Someone just as simple by saying, "Oh, you're doing great, keep going." That falls under this construct under appraisal support. Next slide, please. So why does SST fit the health issue and population? Social support is a strong fit because it aligns with the needs, the challenges, and lived experiences of older men who smoke. It also taps into the power of relationships of community that are often more influential than the individual motivation alone, especially for long-term behaviors like smoking. Uh, for older adults are at higher risk of social isolation. Uh, Men over 55 may usually experience loneliness. They may be retired, they may be widowed, or they have just a shrinkage of social networks. And this also becomes a trigger for smoking or a barrier to quit smoking. Uh, SST emphasizes the importance on the emotional connection, which is especially important for those with limited social interaction. Smoking is often a coping mechanism for stress as well. Emotional and informational support can provide healthier alternatives to coping. Long-term smokers often rely on cigarettes to manage stress, to manage boredom or health concerns. SST also supports the idea that emotional and informational support can provide healthier alternatives to coping, such as stress management and encouragement or advice. Finding support through a family member or a peer group is also it could also help replace the behavior that these men over 55 are having with smoking, and it can become a positive reinforcement towards the individual. Older men may be also less likely to seek help on their own. SST focuses on the interpersonal influence, meaning change can come from trusted people in their lives. Again, family, peers, and community leaders are very important for men to be assisted in leaving this health behavior. Research shows that men, particularly older men, are less likely to seek professional help. Therefore, it is a lot harder for them to quit smoking. Supportive relationships can encourage men to take the first step towards quitting. Therefore, it helps them get that help in a non-judgmental way. This is also a good fit. SST is also a good fit because LA County has diverse cultural and community ties, meaning that SST since LA County is at a highly diverse population where cultural norms and community relationships play a strong role in behavior, this theory can cope well with leaving this health behavior. Programs can also be tailored to community values and improving both engagement and outcomes to reduce the health behavior and potentially reduce the risk for stroke. Next, please. The rationale behind this theory and SST. So smoking is a behavior influenced by social norms and relationships. Smoking is often embedded in social routines, meaning that these individuals circle usually they have friends who smoke, so it's a lot harder potentially for them to leave this behavior. And as said initially, that using cigarettes is they also use it as a stress relief when they're alone. Social support theory helps address the social context of smoking by targeting relationships, not just the individual. Social support theory also helps the social context of smoking by targeting relationships. I'm sorry, I think I just said that already. So for men over 55 who have smoked for decades, social encouragement and accountability are next slide, please. So I'll be touching base on the strengths and weaknesses. The strengths for social support theory, it builds on natural systems, again, reinforcing on friends and family and community. Uh, Older adults, especially men, are more likely to change behavior when they feel supported by people they trust. Again, an example like friends, family, and community. It also works well for behavior change in older adults. SST has shown that in public health programs for smoking cessation, chronic diseases, management, and mental health, especially among older, vulnerable, and underserved groups. This can also reduce relapse and risk by maintaining long-term social accountability. The weaknesses behind the social support theory is if someone lacks a strong support system, it's harder to apply. One limitation is that not everyone, especially isolated older men, have a strong support system, meaning therefore they won't have that tool to better achieve that goal of smoking cessation and potentially be at lower risks of stroke. And not all social support is positive. Peer pressure can be an issue as well, depending on the circle of the individual. They could be at higher risk, they won't be able to leave that health behavior because everybody else around them is smoking. Therefore, they're at higher risks of getting chronic diseases and at higher risk of stroke in this case.
Hello. So the following initiative that are looking for in our initiative is going to be the multiple streams theory. So this theory was created in 1984 by John Kingdon. This is also has three constructs, which is also referred to as the three core streams, which are going to be policy problem stream, the policy solution stream, and the political stream. If we look a little bit, if you're looking a little bit closer into the first stream, which is policy problem stream, this is when you are having a problem that is very significant to the point that it is requiring attention, like it can no longer be ignored. The policy solution stream is more when it's been decided that there needs to be a solution, and it has the involvement of experts, academics, potentially individuals in the health field, advocacy groups. This is when you're not just looking to fix a problem and identify the problem, but there has to be a viable solution to this issue that is brought up. And when that happens, that is connected to the next portion, which is the political stream. So this is when politics are involved into the creation of the solution. That means it's between both the public, the government, the interest groups, the election, or political atmosphere of that moment. And the issue with that one is that a lot of the changes that will be brought for that issue are going to be affected by the political landscape. So all changes, all initiatives, all regulations that come from identifying the problem and then finding a solution for it, it ultimately comes down to the political portion, really is going to determine what kind of changes are going to be enacted. Next slide. Now that you are looking at the uh, streams, now that there is evidence of the streams and what they are, the problem stream. So in this case, our the initiative is targeted towards men over 55 who have an increased stroke risk because of their smoking. That is why the initiative is trying to get them to do smoking cessation. So if you look into the research, there's evidence that over time, particularly 5 or more years, there's going to be a decrease in the smoking and the stroke risk when smoking cessation occurs. Correction. And then this is particularly important to recognize that stroke is not the only issue that comes from men over 55 smoking, but also there is a potential for long-term disability for the individual. So that is why in the problem stream, that is like the main concern that the individual needs to identify, well, not identify, but they need to be aware that there is a potential long-term consequence for their health. And then if you look into medical information, there is a lot of disparities with the smoking cessation programs. Particularly, it is harder to reach these kinds of groups of older men, particularly 55 and over, just age-related factors, the way that they connect to programs for smoking cessation might be a little bit more different than if there is a focus on a group that's younger, let's say like 40 and under. Next slide, please. So the smoking cessation, once you reach the policy stream portion of the theory, obviously it has been identified that there are going to be smoking cessation measures that will be taken in that portion. If when looking at the data, there are solutions such as which NRT, that stands for nicotine replacement theory. Those are that is a potential there is a potential thing that can be used to assist the population, particularly the men over 55, because more than likely these individuals have been smoking for a long portion of time. Most likely they have started in their teen years or early 20s. So they are going to have a more difficult time getting rid of their nicotine addiction because they're so dependent on it. And then, as previously mentioned, there are pharmacy interventions and programs that help provide support, particularly for this group of individuals. They have, through research, it has been identified that these individuals will have more solid friend groups, social networks, community ties. So for their smoking cessation initiatives, there has to be an emphasis on not just counseling, not just providing medication therapy, but also providing community level support and support that comes more so from people in their same situation, so same age group, and just within their own personal network, so social, family, workplace, etc. And then these are going to be a lot of the main challenges is just getting them into a system of support in order to be successful at the smoking cessation. Next slide. So for the political stream, as previously mentioned, there will be there is already a issue identified. There are viable solutions. But when it comes to political stream, it really comes down to making sure that the policies and regulations that are in effect will be able to support the smoking cessation efforts of the men over 55. Certain individuals, 55 and over, they are more than likely to be at retirement age or close to retirement age. And as identified through research, a lot of these populations of men who are older, they struggle with Medicare, just medical costs in general. So sometimes issues that prevent them from having a successful smoking cessation initiative is that they will have cost related issues. At the same time, if they do not stop smoking, or if they're not able to successfully complete smoking cessation, they would be affected more because the stroke will cause potentially health issues that will potentially prevent from working, or it may increase their healthcare costs. So in the long term, if they don't stop their smoking habit, these individuals will have issues that affect them. And then when it comes to the policy, if policies are not created that support these measures for smoking cessation, there will be no success. Next slide, please. So the rationale for choosing the multiple stream theory is that the identification that there is at the community level, there is a larger responsibility when it comes to smoking cessation in particular. These individuals are not going to be able to succeed as much if they don't have community level initiatives, if they don't have support groups that are of similar experience or of similar age, because they will be less likely to relate to them. And then also, we need the appropriate policies in order to have them be well supported in their smoking cessation efforts in order for them to successfully reduce their stroke risks. And the next slide. So the strengths and limitations. So more than anything for the strengths is that it addresses the community level and political or policy change issues that need to be met. It also addresses a lot of the social determinants of health has to be addressed in order for there to be success in health initiatives such as this one, which is the smoking cessation for older men. However, their limitations do not account sufficiently for the fact that, particularly in industries such as tobacco, they will have a lot of pushback and they will try to prevent these individuals from successfully completing smoking cessation programs because it's more beneficial to their profits. And also, it is kind of difficult because a lot of times policy changes are not 100% guaranteed. Sometimes there might be a group advocating, they might convince a certain political figure or person who is in charge of making policy changes, but they're not guaranteed to do that. Sometimes there can be shifts. So that's one of the other limitations.
So in this theoretical framework, in this diagram, it starts with threat perception from protection motivation theory. These are a person's awareness of the risks of smoking, things like stroke, heart disease, and cancer. That fear or awareness increases their coping ability, or how confident they feel in being able to do something about it. This directly builds their contingent self-esteem, meaning they start to feel better about themselves when they take steps forward to quitting. And then there's the perceived vulnerability and severity, also from protection motivation theory. Perceived vulnerability is the belief that, for example, this could happen to me. And for perceived severity is, for example, like this would be really bad if it did. Together, these beliefs strengthen the argument for public level support, which we call the policy stream, like smoke-free laws or public quit programs. And then there's the continent self-esteem, which drives action, which leads to motivation to change, and it drives to actual smoking cessation behavior. And that's the key step, the moment where intention turns into action. And then the policy stream and emotional support working together to reinforce that behavior change. Emotional support comes from friends, family, or counselors, and it makes a huge difference. So, the finally it brings in global self-esteem, which is more stable and internal. This kind of self-esteem helps people stay motivated in their long run, even if they slip up. That's what helps lead to positive health outcomes, things like improved breathing, lower stroke risk, and better quality of life. The next slide. So this is what I talked about for the theoretical framework, which I explained it in the previous slide. In conclusion, preventing strokes among 55 plus male smokers in Los Angeles takes more than just asking individuals to quit. It requires a comprehensive approach that tackles both personal motivation and larger social and policy factors. By using protection motivation theory and self-esteem enhancement theory, we gain insight into the inner responsible reasons why people choose to quit. And thank you so much for listening.